Okay. Is that better?
Let's see. Yes, I
Okay.
see your face.
I'm just going to grab something real quick.
Okay, good.
Okay. Just rearranging my desk so I don't knock stuff over since I'm sitting at the end of it. Okay. I'm ready.
Good. I think we'll just probably wait for a few minutes
Okay.
before we start.
That sounds
And
great.
yeah, so did you have a chance to look through the questions?
I
And
did. I
okay.
did. So I'm anxious to talk. Those are all fabulous questions. Fabulous questions.
Yay!
They really
Yay!
are.
Great!
Pertinent
Great.
today and pertinent, definitely pertinent to breast cancer. So I'm eager to chat about them.
Oh, that's great. That's great. Okay. So, and I know that, this is the breast cancer month. Can you hear me?
I
Is it
can hear
clear
you.
enough? Okay.
Yes.
Because I
Hear
know
me?
there's a lot of noise out there, and I'm just trying to make sure that, you can hear me.
Yeah.
I can hear you clearly.
Okay, good.
So, this is breast cancer month. This is how we just transit into the breast cancer month and start addressing issues. And you know that this is something that's very, very personal to me. And of
Yeah.
course, you too, and the work that you do. So today is we're just going to have a chat with you. So you can teach us one or two things. And for every woman or man out there that has concerns and questions, this will be a good time for everyone to just kind of chime in and be a part of this conversation. Right?
Perfect.
Okay,
Wonderful.
so but before I start, I'm just going to have you just kind of introduce who you are and your background. So for others to know, I know you, but I need
Yes.
for them to know you.
Yeah. You and I have known each other. Gosh, Julia, how long is it now? 11 years?
No, 13.
13 years.
13 years.
And I was so excited to meet you back when I worked at Friedert. I'm a registered nurse, and I've worked as a nurse, gosh, for well over 30 plus years.
Woo.
And I was diagnosed with breast cancer not quite 17, 18 years ago at
Okay.
the age of 41. And at that time, I was working as a cardiac nurse and never thought I would leave cardiology. I loved working as a cardiac nurse. I worked in an intensive care unit and was very passionate about it, and always did volunteer work in the American heart world. After my diagnosis, which happened shortly after I moved to Wisconsin, which was scary because I didn't know the physicians or the hospital network when I moved there. I was diagnosed with breast cancer and had two very young children at the time. It was frightening and overwhelming, as anybody that's dealt with that diagnosis knows. So because I had just moved there and had not yet gotten a job, I was fortunate that during my treatment, I remained off of work. Once I did return to work, I no longer felt, much as I loved cardiology, I knew that two of two things. One, when I returned as a nurse, I wanted to work in the cancer world. Breast cancer in particular is what I started out as. And then two, my volunteer work, I wanted to be in the cancer world. So I started out working for Susan G. Komen, and then I started working as a breast cancer nurse shortly after that. And that's when you and I connected.
Yes.
And I've continued to work as an oncology nurse since that time in many different ways, both in advocacy, outreach, education, as well as in the hospital setting or in the outpatient hospital setting, working directly with cancer patients face-to-face along with the physicians. And it's been something I've been very, very passionate about.
Wow. Wow. So you've not only at Friedert have you worked as an oncology nurse, you've worked with other healthcare organizations as well, right?
That's correct. Because I had started out volunteering for Komen, Susan G. Komen for the Cure, then I went on to be a staff member there. So I also worked for Komen both as a volunteer and as a staff member. That was probably one of the most amazing experiences for me in all of my career, and an amazing experience as a person, as a whole, because I learned so much through Komen with regards to about life and about cancer and about other populations, people that don't have access to care, people that aren't aware of the things they need to know, people that don't have connection to resources. And I met the most amazing people, collaborated with the most amazing organizations, and it was really a great learning opportunity for me to understand what it's like, collaboration, networking. That is vital in order to be able to reach all people. And it was during that time that I became passionate about, there are a lot of people out there that haven't been educated, that don't know awareness, that don't have connection to resources. There's a lot of barriers to care that.
Yeah, I mean, of course, I can attest to that because, you know, from the time we met, and I just, you know, the times I'd ask myself, you know, what makes me very special. But having, you know, you as a mentor and being, you know, coming to, you know, have that opportunity to work with you has been life changing. And I tell people a lot because whenever I travel to Africa and I needed resources, materials, I always called on Tia like, hey Rita, how can I get this information so I can pass it on to the other people? And you never blinked an eye. You always just, you know, helped me provide whatever I needed to help the people. I really appreciate that. And I need people to understand that there are angels working amongst us in everything that we do, because this journey is a very tough one, in the sense that, you know, when you get diagnosed, you just feel like your world is coming to an end. But at the end of the day, when you have people around you that support you, that, you know, keep hope alive.
Yeah.
It gives you the strength to keep working and going further in the things that you do.
Very true. Very.
Yeah.
And, you know, it's interesting because, you know, I'm so grateful that you feel grateful for what I've done, but it's been a mutual blessing. Truly, truly. I have to say.
Thank you. Thank you. You know, but one of the first questions I had was, you know, after my treatment, or rather after treatments with a lot of breast cancer patients, as an oncology nurse, what would you advise us to work on mostly, like to, you know, to better take care of ourselves?
Or continued maintenance of a healthy lifestyle. You know, there are risks, the risks for breast cancer. Some of them we can manage, and some of them we have no control over. We have no control over that we're a female. Women are just more at risk. We have no control over the fact that we're getting older. The older we get, we have no control. So there are certain risk factors that we cannot control. But fortunately, there's quite a few risk factors that we can control. And it's really taking control of your life. Maintaining a healthy lifestyle not only helps prevent breast cancer, but it helps prevent a recurrence. It helps prevent it from coming back. And that means eating more fruits and vegetables. It means not being sedentary, being more active. It also means being very vigilant in following up with your doctor on whatever basis they recommend. For some people, it's every 3 to 6 months, depending where they are after their diagnosis. How far out was their diagnosis and how far along were they in their diagnosis? Eventually, most people are able to follow that maintenance surveillance is what we call it, once a year with their physician. Some people, after a period of time, they feel safe and they think I can stop coming, and they stop coming, or they don't follow up on the medication that's recommended. And far too many times I see those women develop a recurrence. And, you know, that happened just last week, a woman that I saw. And, you know, you never ever want to point a finger at someone. Your first is, oh my gosh, I wish you would have listened. Listen to your doctor. Follow whatever recommendations he's given you.
Okay. Okay. When you say healthy life choices, I know you mentioned your fruits and vegetables. You know, many times I would speak from the African woman perspective.
Okay.
We have certain food styles that we are used to. How would you recommend, in terms of, different cultures and what they're used to,
And
you
that's
know.
that's another
So,
great question. And that's something that I really gleaned a lot at my time with Komen is, there's never a template answer because everybody comes from a different place. So, depending culturally what your foods are, you want to make sure your foods that are lower in fat. You want to get a little bit of protein. You want to maintain a healthy weight is very important. So whatever within your, natural food intake, as long as you are getting balanced nutrition, as well as maintaining health, moving, exercising, even just walking, you don't need to be engaged in vigorous activity.
okay. Okay. Well, another question I have is, when I was going through my treatment, they recommended the clinical trials. Is that something that, as an oncology nurse, you think should be recommended for every cancer recipient, and why?
Yes, not necessarily for every cancer recipient. The way
Okay.
breast cancer is determined, there is it's called the NCCN guidelines, and that's the National Comprehensive Cancer Network. That's a government body that follows research, and it comes up with all of treatments and how a cancer patient should be treated. We treat them as individuals, but we take a look at their diagnosis, their age, their underlying other conditions, and we develop what's called a standard of care. So anybody that would come in with breast cancer at a certain stage, now they're looking at all the pathology and everything else. It's very, very complex, but there is a standard of care of how we would treat that person, no matter where they go.
Okay.
But that said, unfortunately, sometimes people, what will happen is, as we treat them with that, a couple of things can happen. One, they develop what we call toxicity. They're not able to tolerate the treatment anymore for a variety of reasons. It's too exhausting on their heart. They have terrible side effects. Or two, their cancer returns or progresses despite that treatment. When that happens, within those guidelines, there's a next treatment to fall on. Unfortunately, for some people, they eventually exhaust all treatment options. Once that has happened, that is a wonderful opportunity for clinical trials. And anybody receiving cancer care should be offered clinical trials, and I highly recommend them. Clinical trials have saved many, many lives. Physicians typically, when their patients have, when their patients have exhausted options, we send old tissue off to, there's a couple of different organizations that will test that tissue, look at different markers, and connect you to a trial and say, we've thoroughly looked at this tissue and how this cancer works, what's feeding it, what will it respond to, and then you can be matched. These are all the clinical trials that exist that can treat that person that is now out of options, and we then connect them to that clinical trial. It's a life send. It's a godsend for many people.
Okay, because I noticed that I went quite through a lot of clinical trials, and some was kind of exhausting,
It
and
is.
some, but it was really beneficial to me.
It's exhausting and it's overwhelming, and it takes someone, a physician, a nurse, whether it's the primary nurse, a nurse navigator, to actually be able to take that patient by the hand and guide them to what their options are. Don't ever let anybody tell you you are out of options. There's always an option. Now, that said, sadly, there are some patients that do reach end of life, and that's a whole different conversation. But if your cancer has progressed and you're still thriving, then there are other options, and you should be connected to clinical.
I like the fact that you said, don't ever let anyone tell you out of options.
Yeah.
Because that's a lot of, sometimes we do, as an advocate now, we do come in contact with people that, actually believe that they don't have any other options, or because of the stage of the diagnosis, it's end stage. And I tell people all the time that I was a stage 3C. I did not give up. you know. So it's when you have people like such as you, my oncologist, and a lot of other nurses that were around me, I felt like I had hope, you know, to actually fight it. There were days that I felt really weak and tired, but just having to know that people such as you remembered my name, I think it was really huge for me.
Yes.
And just holding me by the hand and just, you know, just making me understand that I could just keep going and, you know, never give up until there are no other options out
Yes.
there.
Yes.
Yeah.
Exactly.
So, and I thank you for that. And
Or
a lot of all the nurses and doctors,
you were a
you
living
know,
testament to
yes.
trials and the
Thank you.
success they bring.
Thank you. Okay, another question is, you know, given the current crisis, the COVID-19,
Mm-hmm.
what would be your advice to a lot of cancer patients, both those going through
Yeah.
treatments, those in remission, and, you know, what would be your advice
And
to
that's a
them?
great question. And that's one that we deal with on a daily basis.
Mm-hmm.
First and foremost, anybody with new symptoms, anybody that finds a lump, anybody that is concerned whether that they've got something going on, call your doctor. Don't be afraid to come in. Early diagnosis is crucial. It's the key to survival. So if these women, you know, call your doctor. We will arrange for a biopsy. We'll arrange to be seen. It is even with COVID. Fortunately, I talk to nurses and doctors in other areas, and their treatment and seeing patients has dwindled. In the cancer world, we don't stop. We continue to see our patients. So be comfortable in knowing that a lot of people worry, but will I catch COVID if I come through the door? Nobody can come through the door of a hospital without getting your temperature checked, being screened, and answering a litany of questions. So we still see all those patients if you're newly diagnosed. Even some patients that have had maybe they've seen the surgeon and not us yet, not a medical oncologist, and they've received a diagnosis. You do have cancer. We need to treat you as soon as possible. For some people, that's before surgery. They would get treatment such as chemo. So our recommendation to them is we can do telemedicine, a Zoom call with those people if they're not comfortable coming into the center. We deal with it. Sometimes our physicians will make a phone call. So I'm going to break it down into a couple different. First and foremost, if it's a new diagnosis, there is a large amount of urgency. Get in and be seen. We will find a way. Any cancer center will find a way. Some of our elderly patients that are in their 90s, they just come once a year, sometimes twice a year. Our doctors will call them. We will do a telemedicine. We'll do a Zoom visit with them. So there are ways to get around it. Don't think that your treatment or even testing needs to come to a halt.
Okay, so when you talk about telemedicine, how does that really work?
Yeah. Telemedicine in our center and in most centers can work a couple of ways. We will arrange, we'll tell the patient, now most of the doctors I work with 9 different physicians. They do both telemedicine, Zoom calls, and they see patients face to face. And we will oblige to whatever the patient prefers. Telemedicine, the doctor literally picks up the phone call at a preset time and calls the patient, and they talk on the phone. The Zoom call, we literally use the app Zoom, and the secretary connects the doctor to the patient, again, at a predetermined appointment. They're literally given an appointment time. So both those methods work wonderfully. You lose the benefit of being able to do a clinical exam. There is so much to be said for a clinical exam. So if somebody is newly diagnosed, that, of course, would be our preference. But do know that if we encourage you to come in, we're bringing you into a safe environment, even with COVID. Active treatment patients, obviously, they need to come in. We can't give you chemo without you coming in. Once again, we make it very, very safe. Anybody that is going to the grocery store, the drugstore, I guarantee you, if you're doing that, it is safer to walk into the hospital.
Okay. Okay. Well, in terms of, what you just mentioned, the telemedicine and, regardless, do you ever encounter international patients that have concerns and questions about, their diagnosis?
Yes, actually we do. Where I'm living right now in New Jersey,
Mm-hmm.
close to New York City. And so we have really stellar care, and we have a high volume of people that move back and forth. We have patients from Haiti, patients from Europe, patients from Asia that will literally
Mm-hmm.
fly in for their care. Um, that can be more challenging, because of the time difference. It makes the telemedicine a little bit more challenging. A lot of those patients I noticed that were coming back and forth actually are residing here right now.
Okay.
Yeah, so we do see a bit of that. That gets a little bit more challenging, but we work with what we have to work with. And our
Okay.
doc will happily communicate with doctors in other areas to manage someone's care. Many of our patients actually have more than one oncologist. They have some patients that have a summer home or winter home and then also reside in the New Jersey, New York City area. They have two homes and they have a physician in both homes, and those
Okay.
physicians collaborate together.
Okay. And I mean, how does that work? How do you?
Typically, it works. How do you do that? Typically, it
Mm-hmm.
works one of two ways. The patient will decide who they want to be their primary care physician or primary oncologist. And that one develops their plan of care, their treatment plan. And then we'll fax information. They'll find another oncologist, or we may recommend it in whatever area where they live the other 6 months out of the year. And we'll share the treatment plan and clinical notes and documentation along the way.
Okay. Okay.
One person has to be the ringleader. One person has to be driving the bus, because, that you can't have two physicians that might have two different ideas. Not that both ideas aren't great, but if the treatment's going to flow smoothly, then you need one person who's leading the bus.
Okay. Well, I asked that because, and I know a lot of times when it comes to breast cancer diagnosis, coming from Africa, or
Yes.
not just Africa, a lot of women or men shy away from presenting it too early, or even shy away completely, either due to cultural stigma
Yeah.
or just the fear of shame or just fear in general. Because I've had situations where when I was in remission, I've had situations where I was called on to be an advocate and speak to a lot of people from the African descent about, presenting early, and some people that didn't want to because they didn't want to be ridiculed. So how do you ever encounter such, and how do you address that?
Yes. I don't encounter it as much as I used to. So I'm going to step back to when I worked for Komen, and I encountered it a lot when I worked for Komen. Sadly, there's so many cultural nuances that exist, and I was amazed. That was one of the things that I learned with Komen that stayed imprinted in my mind. As you mentioned, in the African culture, a lot of times people shy away. They feel as if they've been labeled, or people are going to scorn them. In the Latino population, sadly, by and large, they feel unattractive, unworthy. I've had some Latino women tell me that their spouse left them because they're dirty or they're no longer desirable. And I'm not judging. I'm not being racist. I'm just sharing cultural nuances. In the Native American culture, they believe that if you even say the word cancer in front of them, that you have then almost cast a spell on them. And these are things I had to learn when I worked for Komen, because I would give presentations to these populations, and I had to understand what was appropriate and what wasn't appropriate. So I saw those stigmas back then. Sadly, I don't see the stigmas as much now, mostly because, unfortunately, those demographics aren't reaching me. If they have the fear or stigma that I shouldn't go to a doctor, or if I have cancer, I'm going to hide it, then they're not getting treatment. So what we do, what communities do, community health, is to try to spread breast health awareness, so that to knock down the barriers to care. We do within our hospital have a navigation team that works on some level with community education to help decrease what we call barriers or access to care. And cultural stigma is amongst that, part of that.
Okay. Okay.
Yeah.
Because I know I worked with great organizations in Wisconsin, such as Nurses Affecting Change with Bonnie Anderson and the rest of them, that
Yes.
I was part of that opportunity. Yeah, I had the chance to work in the community with them and doing breast health care, and it really opened my eyes to a lot of things. And I know that a lot of people don't even want to come out and talk about it. No. Still the struggle we have here today. Yes.
And that's where organizations, and Bonnie Anderson is an amazing woman. She's a trailblazer, and Bonnie would literally just show up on the doorstep of people's homes to take them for treatment or screening. Bonnie would go to street corners and find and help people. I just adore that woman. There's other women like her, and they tend, but they work for organizations such as Gilda's Club, and there's some that work for American Cancer Society, and those organizations are in all communities. And fortunately, they have a great influence on those cultural stigmas, because they actually tend to work off of grants. They're nonprofit organizations as yours that are able to develop grants and programs that reach these underserved populations that don't have access to care, and they help guide them into treatment centers, screening centers, and they are amazing people that work for those organizations.
Yes, they are. So, Rita, what would be your final, what would be a takeaway that you can give to cancer patients, cancer recipients such as myself? Because we're still learning, we're growing, the work continues, it never ends. We just keep doing what we have to do to help other people to pay it forward. You guys gave me the strength. You, Bonnie Anderson, and so many other great women out there gave me the strength to do the things that I do today, in helping a lot of women out there, doing the things that I do. How would you advise us advocates to keep doing the work that we do? And to the cancer patients who are, dealing with loved ones, people who are actually dealing with loved ones that have been diagnosed with this disease, what would be your great advice to us?
My advice would be to reach out to your resources. And that can be hard to do. A lot of times people don't know what their resources are. And you can start with Susan G. Komen for the Cure. Look at their website. They have a plethora of other links that will link you to so many things, whether it's emotional support, education, financial support, which is a huge barrier to care. The American Cancer Society as well. There's a Gilda's Club, many locations. Those are great resources. I would strongly recommend maintaining that healthy lifestyle, being active, eating healthy, maintaining a healthy weight. Those are key to preventing a recurrence. Don't be afraid to ask for help. Many people are afraid to ask for help. When somebody is struggling and they're going through treatment, anybody being treated in a cancer center, there's social workers that can also connect you to resources that are available to you in your own backyard. So ask your nurse or your doctor, let them know, I need A, B, or C, whether it is financial support, maybe it's transportation issues, maybe it's childcare issues, maybe it's emotional support, because that does exist. It's sometimes hard for people to find where they can be connected.
Okay. And also in the work that I do, a lot of times I travel internationally to work a lot of these women. how would you best advise for women who are not able to, of course, get as much help as those here in the United States? What are the resources that could be available to international women? Because I hear a lot, a lot of times I get presented with women who are actually undergoing this
Yeah.
diagnosis and don't have enough resources or help. How can we help these women more?
Yeah. Fortunately, Susan G. Komen for the Cure does have international resources, and they have resources for all demographics in numerous languages. That's first and foremost what I would recommend for breast cancer in particular. I would also recommend the American Cancer Society because they do collaborate with other organizations that they could connect you with, which I think is huge.
Okay. I'm just putting all this down because
Yeah.
these are resources that I think are very useful to a lot of women. So, okay. Well, I want to thank you so much, Rita.
Right.
You've been a lifesaver of mine. You continue to mentor me. And I'm still hoping that one of these days I get to take you to Africa with me.
I am going to Africa with you sooner or later, Juliet.
Yes,
I promise you.
because
I'm
the
trying
work
to make that
continues.
happen, and we will certainly make that happen. That is on my bucket list.
Thank you so much. I really appreciate this, and I cannot wait. I cannot wait.
I adore you. Thank
Thank
you.
you.
Bye-bye.
Okay.